Bienvenue à la session scientifique du département de médecine familiale de l'Université d'Ottawa. La session se veut bilingue. Vous êtes invité à poser vos questions dans la langue de votre choix. Bonne session. Cette présentation sera enregistrée et disponible sur la chaîne YouTube du département de médecine familiale. En poursuivant la session, vous consentez à être enregistré si votre caméra ou microphone est activé. This session is being recorded and will be posted on the Department of Family Medicine YouTube channel. By continuing the session, you are consenting to be recorded if your camera or microphone is activated.
Bonjour, bienvenue. Welcome everybody to actually the last family medicine grand rounds of this academic school year. Just to let you know, we do take a break in July and August. My name's Doug Archibald. I'm the Director of Research for the Department of Family Medicine, and I'll be moderating today's rounds. And we have two great speakers today. Our focus is going to be on the undergraduate medical education curriculum. Our first speaker is Dr. Chen. And Jean is an attending staff physician in the Department of Emergency Medicine and the Assistant Dean of Curriculum for UGME. She was recently nominated for the U Ottawa Hospital Excellent Leadership Recognition Award, and her research focuses include medical education leadership, research, and wellness. And over the years, I've had the privilege of working with Jean on medical education projects. So it's great that we can have you here today, Jean. It's wonderful. As well, joining Jean is Dr. Laura Muldoon, who we all know, family physician at Somerset West Community Health Centre here in Ottawa. For the past 2 years, she's led the Medicine and Society curricular pillar in UGME and has learned to appreciate the excitement of designing new ways to engage and motivate medical students. Her research interests include primary care for people with barriers to access to health and healthcare, and the functioning of interprofessional teams. So with that introduction, I am going to turn things over to Jean and Laura. Good to see you all today, and go ahead.
Thank you so much for having us. I didn't know this is the last grand rounds of the year. I mean, I ought to know that, but so this is a very special place, and we're going to make it worth your time bright and early. So we're hoping to highlight some of the activities in UGME and some of the directions. And there is a reason why we're coming to you, because you are the curriculum and you are the backbone of the physicians we're forming. Before we start, I do want to acknowledge that we are in the land of Anishinaabe, Algonquin Nation, First Nation, Inuit, Métis people, and this will come to light in a bit as we talk further. I don't have relevant financial conflicts of interest to disclose, and neither does Laura.
Thanks, everybody. We're really glad you're here today to listen to us talk and to share with us your ideas about how we can improve undergraduate medical education from a family medicine lens. And so our learning objectives today are to talk a bit about the evidence base for why family medicine teaching actually helps to shape students' career choices and their professional identity. And I think there's more evidence for that than you probably imagine. We also want to talk about, and we can never talk about family medicine teaching in undergrad without talking about the hidden curriculum, about role modeling, and exactly how the environment really affects students' choices when it comes down to their decisions about what to do in the future. And we're going to talk about how UGME and at U Ottawa is trying to make some changes to improve the status of family medicine in our curriculum and to hopefully help you figure out how we can work with you to improve what we're doing. That's kind of paraphrasing that final objective, but there we go. Okay, so here's Dr. Glaucom-Flecken, as I'm sure you all recognize. And I think, Jean, are you able to share the video? Or so you will see a video here about what we don't want. Oops, we can't hear the sound. Can you share the sound, Jean?
We can see the subtitles.
Yeah, we can see the subtitles. It's good. We'll just keep going. Okay, that's great. So basically what that, in the typical Dr. Glaucom-Flecken way, that sort of represents how we sometimes perceive that our undergraduate students are being educated. They're being trained in the minutiae. They don't have any sort of practical knowledge or any idea of what the big picture is. And that's where we are trying to make some changes going forward. Well done, Jean. You're back on the slideshow.
The video that was make me nervous. I'm sorry that was a bit clunky. Laura.
Okay, yeah, still me. Okay, right. So why are we talking about this? Well, I don't think anyone in this room really needs much information about that. We know that we've had a family medicine crisis, which has been escalating over the last few years. We also know that, medical students are not choosing family medicine, and those who do are not choosing comprehensive practice. There was a great paper that was written by a bunch of people in this room last year or the year before about that very problem. We know that even if students come to medical school with the idea that they might want to be family doctors, they often get talked out of it because the hidden curriculum is so strong. I'll just do a quick anecdote here. One day I was giving a talk on primary care to the first year class, and after it ended, there were 3 women who were kind of lurking in the corner, waiting till everybody else left. And then they came over to me and they said, "We want to be family doctors, but we don't dare say it because our colleagues and our teachers say things like, well, you're smarter than that, or why would you do that, or things like that." So, I mean, the hidden curriculum is not even all that hidden, to be honest, according to these young women in any event. And of course, family medicine preceptors, if you're working in your office in the community as a family medicine preceptor, I'll bet you almost nobody knows, except the office who has set up the student with you, that you're doing that. They definitely don't appreciate you in much of a way, and that's also a big problem. So we need to improve that part of the system. And as this says, the good news is that we can modify all these things, and it says, and you are the lever, but I would also say, and we in UGME will help you be the lever. You can't do it all by yourselves, and we wouldn't expect you to. Next slide. So, of course, as we all know, as the previous slide alluded to that as well, is that, family medicine is being chosen less often. A projection that was done about a year and a half ago was that 4.4 million residents would not have a family doctor in Ontario by 2026. I think that may not be quite accurate now because of the work of Jane Philpott and the Primary Care Action Plan. But there is still a vast number. I think it's 52% of family doctors have said that they either plan to retire or cease practice within the next 5 years. So even if we're sort of temporarily starting to look a little better, how long will that last?
Earlier, Laura alluded to some of the phrases like the hidden curriculum. So we're just going to take not too long. This is not a meta talk, but we know about this kind of hidden curriculum, and there's a few papers written in the 1990s. So that's 30 years ago now. To me, the 90s was 10 years ago, the best decade. But the hidden curriculum is a set of influences that changes or affects the functions at the organizational cultural level, and it's outside of the formal curriculum. So Laura gave a very powerful anecdote about this kind of quote unquote bad mouthing. And it is very common in medical education. And there are studies that's done to, and we certainly have the reference that we can share at the end, but it does influence students' career choice. I'm pulling some of the data from the States because, as you know, they're 10 times our size, but 76% report hearing negative comments about specialties, with family medicine among the most frequent targets. Importantly, 17% report changing their career choice because of these comments. So this is not just academia talking, but these hidden curriculum has ramifications. And of course, we know that the students are entrenched in academic because they're in medical school. So these kind of unfounded bad mouthing has important societal implications. And they also shape who they think they are in terms of their identity. As many of us know, some of the professional identities can spill into personal identity as well. So it goes both ways. They learn not only about formal teaching, but also about what they see, what they hear, and what they witness at work in these training environments. Now, it's not all gloom and doom. Because when they see strong positive family medicine or family doctor models, it does attract students to family medicine. I taught ACLS 2 days ago, and that's exactly what they've told me. They want to go back to Milton because they shadow their childhood family doctors and they want to be family doctors, quote unquote, growing up. So with that as the backbone, we know that there are interventions that we can produce or design that can improve this kind of exposure, working on the mentorship and address specifically the hidden curriculum. Again, I'm not going to belabor the role modeling, but we know there's the evidence is no longer emerging. It's there now. We know that role models attract and conversely deter learners from family medicine, and the effect for our specialty is more so than other specialties. And here are some traits of powerful role modeling. So clinical excellence, being great doctors, great teachers, and I see Leonard Bloom here in the talk, humanistic qualities such as compassion, integrity, and honesty. It integrates values into their core belief system as a human being, and it influences how they conduct themselves as physicians. And it does have trickle-down effect on the workforce, shaping and of course, attract and deter our learners from our career. So it can be used as a conscientious strategy in education. Laura.
This is me now?
Yeah.
Okay, perfect. Thank you. And so, this is the idea of belonging is a very powerful thing. And I think as family doctors, we get that. We know that if people are feeling excluded or othered or just not part of the whole scene, they don't engage, right? And so the evidence that's emerging now is that in terms of role modeling and in terms of including people in your work in the office and encouraging them to move on and stick with family medicine, you have to make them feel like they belong. And so that means things like, and there's 4 tips that this paper came out with, which I think are brilliant. Number 1, onboard students effectively. Orient them, name their role. Don't just sort of have them come into your office and say, here, put this stethoscope around your neck and follow me. Explain what they're doing, explain what's happening. So that does involve a little bit of time. Secondly, foster inclusive team dynamics. So make them part of the team. If you're working with a nurse, if you're working with other professionals, make sure that they get introduced and that they are included in the team culture. These things seem kind of self-evident, but it obviously doesn't happen all the time if people have to write papers about it. The third thing is involve them meaningfully in patient care. So in other words, don't just have them trail you around from room to room, doing nothing, answering none of their questions, and not explaining what you're doing. And fourthly, provide high quality supervision and feedback. So these are, excellent rules for teaching for anybody in any situation, but really very important in family medicine. And of course, in terms of what we teach in family medicine, we are really one of the most important settings where they'll learn in medical school. We are able to show them what real medicine is. So we have patients who don't come in with labels already. They come in completely undifferentiated. They come in at different points in the natural history of their illness. We also can model things like continuity of care, whole person care. And so a lot of these things are actually hallmarks of what we call generalism, and we'll get to that in a minute. But I think in terms of family medicine, what really makes us stand out is that we have generalism in our bones. It's bred right into us, and we on top of that have the family medicine specialty. Unfortunately, as I said earlier, family medicine teaching is not always obvious. And so it is in the academic units, obviously, but in the community, it's really harder for family doctors to do some teaching because, first of all, they're part of their own clinical community. But really, if you're out in the community, you don't feel very part of the medical school. And you don't really feel very much part of teaching. Nobody's sort of encouraging you to get more, CPD on teaching and such. And so as a result, the family doctor who's sort of alone in their practice in the community doesn't really identify strongly with being part of the medical school or being part of that community of teachers. And that's something that we probably need to change because we know that teachers who feel recognized and if they are supported well, they will actually want to teach more. They will keep teaching. But if they don't, they'll stop. And there was something on the side of that slide, Jean, but go ahead. Yes, time. That is, I used to be back in the day when I was doing another job in UGME, the students had to write essays about, various important things to do in healthcare. And, they had to list the barriers to why doctors didn't do these things. And of course, they would list a number of barriers. And I would always think, but you're forgetting the main one, and that's time, because you just don't have time to do these things. And of course, according to surveys, that is in fact the main barrier. Okay, perfect. I keep going, Jean, right? All right.
Yuppers, you're doing fantastic.
Perfect. Thank you. So, why do family doctors teach? Well, they don't do it to get rich. And they don't do, which I suppose is no surprise to any of you. They mainly do it because they love teaching. Sometimes they do it because they feel it's their duty to the profession. And in other cases, it's really that relationship with students that causes them to keep teaching. It's very interesting. The whole idea of incenting people to do things has been very popular in the last little while. And incentives can only go so far. They don't always buy you what you think you're getting. And so we do have to be careful about that. And what does this mean? We at U Ottawa really need to build a genuine community of family doc teachers, recognize them for doing that, and help them to do that. And I think that's what this structural friction means here. It means not making it so hard to figure out who you email and how you do this and how do you ask and who's going to pay you and will they even pay you? And if they do pay you, will you know what they're paying you for? Like there's a whole bunch of structural things that really need improving. Okay, so what works? In the literature, we see that longer, higher quality placements can actually change someone's mind about what their career will be. And actually, I mean, I love anecdotes, and I'm sorry about that. N of one study, I do remember not being all that interested in family medicine until I went, when I was in third year medical school, on a rural family medicine rotation, and I was in awe of my preceptor. I thought she just rocked, and that's what kind of changed my mind in that sense. And so that kind of thing can change people's mind. And that's something that we need to really think about and work towards. The other thing that can help medical students choose family medicine is if they don't see family doctors as just those people in the strip mall who are, seeing people with colds, right? So if they see family doctors in leadership positions within the undergraduate education system, in senior roles, they've written their cases that they're studying, they're mentoring them, they're in active roles within the university itself, and they can see that. And then, of course, authentic patient encounters, that is another thing that can really turn, people in that direction. I mean, they come to your office, they're going to see, you don't just see colds in your strip mall, even if you are in a strip mall, right? You see and are part of the lives of many people, and you see many, many, complicated medical situations.
So with all of that said, I want the audience to think about a student you taught. And if you cannot think of that student vividly, think back to a teacher who you remember, who shaped you. And if you cannot think of a teacher during your training, it can be an elementary school teacher or kindergarten if you want to go all the way back. What did they say? Or what did you say to the student? And was it what you're teaching them textbook in either a lecture or small group, CBL, PBL, TBL, all the BLs, or was it off script? So I know this is a virtual setting, but feel free to take a minute to think about it. We're very luxuriously given an hour of your time. So I know we went through a lot of data, stats, but now is the time to let it all simmer. Anyone have any thoughts that they feel like sharing? Am I allowed to pick on Carol?
Of course you are. Oh, Yolanda has your hand up too.
Oh, Yolanda, Dr. Turley, please.
It's Yolanda. Thank you. I think the other thing that's very interesting is medical students coming in don't really realize the breadth of what family physicians do. I don't know if it's changing or not. I mean, I work in an academic unit, so maybe I have a little bit of a sort of biased view, but I think just showing them as well that family physicians, I mean, I used to do obstetrics, I don't anymore, but I would do these little workshops in the first or second years, and there were many students there who said, I didn't know family doctors, delivered babies, which was, like very interesting to me, but family physicians, we work in like, retirement communities or long-term care homes, hospitalists, we have, Denise Lewis who works at CHIO, lots of people who do things like addictions and all sorts of, so that's the other thing I think is really great for them to see is the breadth. Because it is, I think, like you said, Laura, like, I think they often think of, like, I'll call it fairly simple primary care, but actually there's like this huge spectrum of care. So I think that's another thing we could both talk about and role model.
Cleo is next.
Hi, can you guys hear me?
Mm-hmm.
Yeah, well, I was remembering in first year medical school in Montreal, University of Montreal, like over 40 years ago, we followed a family doctor once, I don't know, a month or something. And this guy lived in a very sort of underserviced area. And he took me like to the pub where they had a communist meeting. I had to follow a lady and interview her. She had one arm. She was on social assistance. She had one kid. So, I mean, just the social engagement, it was a huge learning experience. And yeah, so I had a very early experience, and I know that's more common too now. And I just wanted to say from teaching medical students, I teach prevention and I teach at McGill in Gatineau in French, and they have like a sort of a sessions where, a family doctor or a specialist will come and talk about their career and what it was like and what made them decide. And the questions I often get are, how are you able to know so much about so many different things? And I really have to reassure them that, you learn to recognize common presentations, what's urgent. And also, I really emphasize that how lovely it is, how wonderful to get to see everything, and that it's not a big deal. And the other question I get is like, the medications, how do you keep up with so much? And I say, it's like every specialty. We have our favorites and we keep up with them. So just the anxiety when you're taught about microscopic things, to realize that you can manage a large thing. And I often say that I was a detail person, perfectionist, it worried me. But, when I was in second year, you really learned to handle these things. Anyway, I just wanted to throw that out.
Thank you. And thank you, Yolanda, too. I don't think we acknowledged that is a really important point that you made. And I think Cleo kind of has reinforced your point as well with her example. I just want to point out that there's a couple messages in the chat. Fabian says, I'm so glad you are presenting here today and about this topic. There are some missed family medicine teaching opportunities, or rather untapped potential, that we could implement at U of O DFM together with the med school and our family medicine community in Ottawa. 100%, Fabian, I totally agree. And then Parisa, thank you for this comment, says, good morning. What about the literature on one's personal identity, like race or ethnicity, impacting the student's feeling of belonging? And that's an excellent point as well. So the more role models we've got from a more diverse group of people, the better things will be for sure. Okay.
So to quickly summarize, we just went through a whirlwind of what this audience actually already know, just written in a slide format. We're going to introduce a few things of what we're implementing to hopefully at least tap into some of the issues and some of the proposed solutions that we're implementing. Okay, so the current since I came onto this role in winter 2023, we've set out these priorities conscientiously. We have acknowledged and deeply aware that family medicine needs more support. There's a number of mandates, and one of which is social accountability that the faculty at large is emphasizing. And thank you, Claire Kendall, for spearheading that at a faculty level and for being here today. And in the past 20 years, a lot of our curricular components are taught in blocks or silos. So you have your cardiology block, you have your nephrology, you have your GI, and so on and so forth. But we all know here that a person is a person is a person, not a sum of their bodily functions or organs. So this kind of integration and system level thinking are also outlined as a couple of priorities. And Laura, if you want to take this, because you alluded to generalism, so floor is yours.
Okay, perfect. Thank you. And generalism is sort of our big fifth priority there on that list, because it is going to imbue everything in what we do. And so generalism is not a new concept, even though to many of us it was a new word within the last few years. It's been a priority actually in this country in terms of medical education through the AFMC for over 15 years. But we're only really getting around now to kind of understanding it and trying to figure out how it can be guiding us in terms of educating medical students. So first of all, what is it? Because there are about 75 definitions of it out there. So you may not like this one, but this is the one we're using. Oh, okay. Michael has some comments too. I'll get to you in a sec, okay? Broad knowledge. So generalism involves what Cleo was alluding to in her comment, that wide range of knowledge across multiple fields rather than that intense specialized focus in just one. And so that's something everyone in this room recognizes. Versatile skills, also alluded to by Yolanda's comment. individuals with generalist skills can actually adapt to various roles and tasks. So, we have family doctors who work in oncology. We have family doctors who work in all kinds of settings where they may not have had a third-year specialized training, but they've been able to adapt and start to work in a field that might seem kind of different from what regular family medicine is. And then finally, this holistic perspective, which is something, again, that needs no explanation to anyone here. It's the big picture where you bring together all kinds of data points and diverse information to try and solve a complex problem. And if we move to the next slide, Jean, we'll also see, so University of Toronto, actually about 10 years ago, set up this tool to examine medical curriculum to see how much it sort of aligned with the whole generalism idea. And it's so looking at through the lens of generalism, we see this rainbow of components. So, and if you looked at our curriculum, even as recently as 2.5 years ago, you would have found not many of them. So, for example, portrayal of the whole person in the context of the family and the wider social environment. We did not do that. It was like Mr. John Smith comes in with right lower quadrant pain, diagnosis appendicitis, cut the appendix out. Oh, maybe he might try antibiotics. Okay, done. Next case. So that was the sort of cases we had. Mr. John Smith didn't have any kind of family, didn't have any, financial worries, had nothing really around him. The importance of the doctor-patient relationship also never really portrayed in our previous curriculum, right? Like it was organ systems, and we moved from one to the next, and the heart doctors never talked to the lung doctors, and the person didn't really have a continuous relationship. Respect for the role and scope and of practice of the generalist. Yeah, absolutely. That is something that we already talked about. Early presentation of problems as yet undifferentiated. Well, and that was an issue that we had before. People came in already with their diagnostic label on them. If it's anyone who's done the PBSG program or done any kind of case-based learning, it starts with this is a module about heart failure. And guess what? The patient has heart failure. What do you know? The real patient would not come in saying, guess what? I have heart failure, right? So management of uncertainty and tolerance of risk are huge things in generalism, right? And huge things in family medicine as well. I remember coming home at the end of one day, not that long ago, after my many, many, many decades of practice, saying, I don't think I knew what anyone had today. Because they were all just sort of vague and undifferentiated. Consideration of multimorbidity, we all know how important that is. Emphasis on the role of prevention and health promotion. That's a real family medicine sort of lens on this. And continuity coordination of care. Interprofessional and multidisciplinary team care. That's something else we often leave out. And that's another place where family medicine, with our involvement with community and with other people from other health professions and other professions, period, can really lead. And then advocacy, another thing that family medicine excels at.
And to quickly plug it, Laura alluded to the fact that we examined our old cases, our CBL cases with this score. And Dr. Carol Geller, who is spearheading the whole CBL project, was able to adapt, or actually in some cases scrap and rewrite the cases to ensure the journalism principles and philosophies are weaved into the design of the case. So we do have an informatician showing the before and after of the journalism scores. And I do want to highlight to the team that we're not just all dogs, but we do have strong leaders in the curriculum front. Yes, Carol, you've been name dropped, and Laura to spearhead these efforts.
Yeah, and I will say that, I mean, it's what a huge difference. We had a medical student look before at the cases, and like generalism scores were zilch practically, and now after, it's remarkable that these people in the cases actually have real stories and come from real places and go through the system too, because that's another part, is shepherding people through the system, right? Is this you or me, Jean?
I put it down as you, but I'm happy to quickly talk about this.
Sure.
So we talked about identifying generalism gaps. So our four-year curriculum is quite broad. So we very early on in 2023, 2024 noticed, oh, CBO, we're gonna fix that up. So we are identifying that and trying to adjust it. The hidden curriculum, we also have identified that as something that needs to be addressed. So as you can see at this table, the curricular front, we have strong representations of leaders in from family medicine, Department of Family Medicine. And of course, it's work in progress that we are hoping to continue to increase this representations and adding in learning opportunities of undifferentiated patient early presentation of illness, and not, we already know this patient has appendicitis, let's fix it. So in April 2026, so just 2 months ago, Dr. Shepu had a visioning day where various parties got together and thought of what do we want our graduates and learning environment to be. And this is a synopsis at a very high level that you can see some keywords: relationship, experiences, mentorship, and of course, invested teacher, and of course, integrated with community that Laura alluded to.
Okay, what do you want me to do this one, Jean?
Yeah, I think I messed up on the speaking because I think I did a 180.
We can tag team. It's all right. Okay, so here are some of the things that have already happened. And so Jean came on, as she said, a couple of years back, and under her leadership as the assistant dean, a few things that have really been super important have happened and have been a ton of work. So let's just talk about a couple of them. So first is what we call MDFM, or the Family Medicine Focus Stream. So you've probably all heard of Lakeridge, which is Queens's program that is a direct entry into family medicine. This is a sort of U Ottawa mini version of this. It's just starting this fall. It's being led by Allison Eyre and Sylvie Casey, and I know Doug Gruner is doing a lot of work with them as well. But I don't want to spend a lot of time talking about this, but this is one of the ways where we're hoping to get people who are interested in family medicine, start them off in a way, form their professional identity early, provide them with all those mentorship and coaching activities, and then have them pass directly through into a family medicine residency without having to go through all the CARMS nonsense, which honestly must be such a gift. But they're just starting this fall. There's only 8 students, 4 English and 4 French, that are beginning in the fall of 2026 into this program. Jean's already talked about the CBL rewrite, a massive amount of work that mostly Carol, but somewhat all of us have done to totally change the CBLs to make them actually interesting and real people, and they're night and day compared to the old ones. So bravo, Carol.
Ooh, Laura, I forgot to say Karen Ferguson.
Oh, and Karen Ferguson, my apologies. Yes.
All good. She did a ton of it. And thank you, Karen, for tolerating me, pestering you with the cases, and of course, as many of you know, the cases, the way that we inherited them are many of which from a subspecialist lens. So to really rewrite them, holy moly, thank you, Karen.
Yes, Karen and Carol, my apologies. The pair of you really were the main leaders of that project, for sure. Okay, and then finally, not finally, but the next thing that we're doing is Jean inherited a hodgepodge of learning objectives and curricular program design. There were almost 8,000 learning objectives for UGME, which, when you think of it, is like an unbelievable number, and they weren't very well organized. And as a result, sometimes you'd get 3 different objectives that basically all said the same thing. And so this massive project of mapping the curriculum, cleaning up things that shouldn't be there, tagging objectives so we know where they actually belong in the curriculum is underway right now, and it's involving all kinds of people, IT and and educational experts and all sorts of things to help us do that. And then finally, the Master Teachers Initiative. Now, there's a fair few family docs who are already involved in this initiative. In fact, I think most of the master teachers are family doctors. And so what this is recognizing and investing in generalist educators. And so these are people who are going to do more teaching than your average bear. They're going to do both in-classroom teaching and small group teaching and also clinical teaching. And they're going to help us form the curriculum as well. And so I think, I don't want to name everybody because I'm going to miss people for sure, but there are a few of you on this call, definitely. And we're still accepting applications for master teachers if you are interested.
All right. So let's switch our brain a little bit about concretely what a timeline is and what it means to you. So we talked about what we want the new curriculum to be, but then from now to 2028, when Dr. Chaput is envisioning a brand new curriculum, so the reform, we still have our legacy curriculum, right? So we're still improving what we currently have with the mapping, master teacher, CBL, and so on. So we still have 4 years of students learning the way we are with improvement. Dr. Chaput has the vision of a brand new curriculum in 2028. So the year one in 2028 will get something that's totally different. That's no longer block-based. So in between, we will basically have 2 cohorts experiencing 2 curriculums, 2 curricula. So we have learners already in the pipeline, continuing with the current curriculum into 2032. And of course, the new curriculum will start in 2028. So with all of that in mind, the audience here is exceptionally important for both cohort. If you have interest in playing a bigger part, master teachers, talk to Laura, talk to Carol with the new curriculum, with the family medicine focus, talk to Allison. If you have interest in smaller parts, because let's face it, life is busy. If you cannot commit to become a master teachers or implementation lead or you name it, then sign up to teach, to precept. What you do now is critical and crucial for at least the next decade of our grads. So earlier we alluded to the April visioning. A higher level review is that, we did, again, walk the talk, talk the walk, walk the talk, you get me, is that we have student participants at the visioning, and without a doubt, they've said that they want to see real patients from the start, not simulated, not virtual, not on a screen, not animated, real patients. They want to grow their knowledge with reality and authenticity. And we talked about relationship, and we talked about integration of communities. So Francophonie, thank you to Stefan. I see your beautiful face on the screen. Indigenous representation, and of course, many of us are quite aware that there are underserved pockets, even within the urban city of Ottawa. We specifically have identified this in our visioning day, and we specifically, at the forefront, thought about the roles of family physicians in the beginning, and not, oh wait, no, not an afterthought whatsoever. So,
okay, so is this
Laura,
me? Yeah,
yes.
Okay, perfect. So the most important slide is actually the next one, but I'll just allude to a few things that we're going to talk about at this point. So we may be asking you if you can take more undergraduate students. I want to say the next slide is how can we help you? How can we make this better for you? So go back then, Jean. So I'm gonna say what we're probably going to ask you, but then we need your help to figure out how to make it work. You can offer to be part of curricular delivery. You can come, you can do sessions for us, you can work in small groups, you can be a master teacher. There's all kinds of things all kinds of ways that we can include you that way. And the main thing is, as this whole presentation has been about, that you can influence the entire class of graduates either to become interested in family medicine and become family physicians, or to become specialists who get it, to become specialists who know how to work with family doctors. Let's face it, at least 50% of our class are going to be specialists. But what we want are specialists who know how to work with us, who respect us, and who, understand that generalist lens and the kind of levels of technology we're dealing with in our offices, because that's the part that always floors me. It's like, oh yeah, just order a CT scan tomorrow. Yes, right, sure, I'll do that. I'm on it. So, and as a result, they can be more attuned to how the system works. And as I said, consider a career in family medicine, hopefully, for a larger proportion of them. And so the next slide, how can we make this work? How can we make this work for family doctors? Thank you for this whole hour, Doug, because this is what we really need to hear. And so there are lots of comments in the chat about some of the some additional things that we needed to consider when talking about generalism and family medicine, and very appropriate. So I think we'll make sure we get a copy of the chat, Jean, at the end of this. I see Fabian's hand, but I'm going to go to Michael because he was trying to put his hand up for a long time. Fabian, I'll go to you next, okay? Oh, maybe he can't do his microphone either. Is he still here?
I think I'm on.
You're on. Perfect. Yeah.
Okay, so this may turn into a rant, and if it does, Laura, just cut me off. So, as many of you know, I'm retired. I've been in the department forever. I've been involved in undergrad for a long time, and it's interesting because the issues that were brought up today are the same issues that have been brought up over and over again over the years. When I was interim chair, I found some minutes from an undergrad meeting that was 20 years old that could have been identical to what we talked about. So unfortunately, these problems exist. As a school, we've gone from a 50% CARMS rate of students picking family medicine to closer to 30. And at the same time, there was no real change in what we were offering as far as teaching. We didn't suddenly do a worse job teaching, but the issues in the community and cultural issues changed, and obviously changed what happened with students' choice. At the same time, I think in some ways we had a step forward because we developed this first and second year program. We were bringing students in doctors' offices. We were so proud of ourselves. We thought this was like a dream come true. And then COVID happened, and I think I don't know what happened to the program, but I think it fell apart. So we were asking, and you're still asking, all of us who have stress in the office and are just barely, managing and functioning to take on students. And not always with the kind of attention and respect that you guys gave us today. By the way, it was a great talk. So I'm just bringing that up to say, I think the DFM has a big role to play here. There's a new chair coming. I think it's a time to treat student education as a priority, as we're sort of saying here. It has not been done in the past. Unfortunately, student teaching in the units and student teaching in the community is not necessarily a number one thought. And it really has to be for all the changes you're talking about to happen. It has to happen. So asking us, how much more can you give? Tough, but maybe that question has to also come with the new chair of family medicine sitting beside you, and saying this is what we can give you, because something has to happen to make that change, to make people feel respected and valued and part of, etc. So I think I'll leave it at that. Oh yeah, one last question. Can you comment on what happened to the horizontal curriculum in other schools like Queen's? This is something that we talked about forever, and we kept saying that, oh no, we can't do that here. It's too logistically difficult. So maybe you can make a quick comment about that, and I'm going to stop there. Thank you.
Okay, before I let Jean comment on the curriculum thing, because that's her specialty, I just want to say, Mike, thank you so much. I mean, you've named it really well. That is for sure a perennial issue, and we all know the stresses. Like I look even in my own practice, and my younger colleagues are like, I'd love to take students, but I just can't. Right? So it's a real thing for sure, and it's something we need to sort out. Jean, do you want to comment on the curriculum thing?
Yeah, and I'll just very quickly add an anecdote. My husband, family doc, he did say, well, you got to change the system. But let's face it, changing the entire system from funding, from government, from public, that's kind of outside our purview. So my response is like, I'm gonna do what I can. I can't change the funding. I'm not the one with the purse. So in terms of the curriculum, you're right, as in we actually do want to do the horizontal longitudinal thing. And the implementation logistic, the feedback was that we can't, we have to blow it up. So that is 2028, the blown up curriculum, where it's more horizontally threaded. There are also vertical threads on top of it. And as you have already imagined, the Medicine Society thread is going to play greater and greater prominence. I think it's Fabian, Laura.
Yeah, Fabian's next. Yeah.
Can you hear me okay?
Very well. Thank you.
Thank you. Thank you so much for this talk. I think when I read the dream, I think there is a reality that or it could become a reality. I'm so glad that you're looking at longitudinal placements. So I'm a family doc who works in regulatory medicine for Health Canada, but I also work in a retirement home, and I'm a little bit involved with the DFM here and there, and a little bit of research and so on. I would love to see what we do with ePortfolio, where we have this relationship with a student over the 4 years, because I can see that they do have respect for all specialties, and that can change over time. So my influence as a teacher is quite immense because of that relationship that has been built up, and I have good chats with them. Where I see an opportunity is placing med students from first year for the first 2 years in a community setting, like a retirement home, not long-term care necessarily, somewhere where they are actually needed, where there is no teaching right now, where there is lots of work opportunities. You talked about relationships, learning about systems, learning about people, learning about complexity, multimorbidity. That's where it takes place. It's the most complex people that use our ERs the most often, more than long-term care, 3 times as much. But there's no student there. There is staff there that are willing to teach from a nursing point of view. There is people who are willing to do rounds. There's willing to do rounds. So I've had a student for 2 years, for example. I've trialed this myself, and they prepared the rounds for me. They became part of the team, and I actually paid them a stipend. I'm going to present this at the DFM retreat and have the student hopefully talk to that experience. There is another opportunity at CHIO right now. At CHIO, we have, as you know, we have grown-ups there that also get sick, but there's nobody that can take care of the parent at CHIO. So they are thinking, okay, what can we do? Can we implement some sort of family medicine system within the hospital for the parents that are sick? This is a great opportunity for the DFM to stay, sort of come up with a program where we have first, second, third year students maybe on a rotational basis to cover that service with somebody within DFM as a lead that can come in and do the consults. It's about 60 consults a year. It's very small, but there are lots of opportunities around just from my little network, and you probably have many more. So there's too many silos and too many missed opportunities. And I thank you for rethinking and for not giving up.
Thank you, Fabian. What interesting ideas. Those are really cool. Thank you for sharing them. And we need to look into things like that more, because we are going to need more and more and more and more placements with family doctors in the community for sure. The chat is sort of blowing up here. Can people who want to speak also put up their hands? Yeah, Alan, I see you waving, and then Doug after you.
Yeah, sorry, I can't. I can't figure out how to use the digital hand. No, thank you both. That's you encapsulated everything brilliantly. It's stuff I know and my colleagues know at Primrose. We've been thinking about and talking about for years, the problems. I just a couple of things came to mind. I was wondering, and this is just rhetorical, are we choosing the right people to go into medicine in the first place? Because thinking like a generalist actually requires a different way of thinking about problems and things. It's not, I mean, the thing about family medicine is you still need to think like a specialist. You still need to think in very deductive terms. You need to know your medicine really well. I remember, as a resident in first and second year, my only priority was not to kill anyone. And that took so you're constantly thinking about the medicine all the time, and I think that we need to uh, really show that family medicine requires a lot. It's hard, it requires a lot of intellectual rigor, but also emotional. It's emotionally very taxing, and I think that's one of the things that students find hard. And I don't know if we pay enough attention to that. And that's why people don't want to often go there. This is hard work. To think like a generalist, you need to be able to think, inductively and abductively as well as deductively. But, having done this for quite a number of years, the residents, I've been mainly doing PGME stuff like postgrad, the residents that find it family medicine, I think, more, I guess, challenging are the ones that didn't just do pure science degrees. So I'm just wondering about that. That's just, again, a rhetorical thought. And of course, and I'm ranting here, because our residency is so short, there can be a perception that family medicine is easy because you only need 2 years. And reflexively, I think that it's obvious that it's a very tough job. Anyway, I just really wanted to throw that out there. I really appreciate all the work that is being done at UGME. It's existential, actually, I think, for our profession that this be done. So thank you both.
Great. Thank you, Alan. So well said. And yes, that the notion of who we are admitting has definitely arisen several times, and that's something where we need to take some action. Now, Doug, you had your hand up.
Yes. No. A couple of very quick comments, if you don't mind. And if people can stay on for a couple extra minutes, I mean, this is fine, right? We can continue the conversation if you're able to. But first comment, actually, as you were speaking, Alan, about admissions, everybody keep your eye out for Meredith Vanstone. She is the admissions director at Simon Fraser, and she really has shaken things up in terms of, criteria and selection criteria for entry into medicine. Of course, as you know, that program is for family medicine. So I mean, it's early days, right? This is the first cohort coming through, but we need to pay attention to these things. Second thing, really struck me when you were talking, Laura, about the role students can play on the team and family medicine teaching. This is situated learning. And Jean, you're going to love this. It takes place in the 90s. All right. Two scholars, Ladd and Wagner, they came up with this theory, really quite a simple theory, legitimate peripheral participation. So you think of concentric circles with the family doc and the clinical team at the core, students are at the periphery. And so how do you bring them into the core? Well, there's different mechanisms. The main mechanism is around language and an assumption that you have time. So this idea of longer clinical placements, is key here. But language. So as you're talking about changing, the language in the case-based learning, et cetera, right? That's important. So there's a lot of theory here that supports these innovations. So things going forward, hang your hat on legitimate peripheral participation. I mean, it will go a long way. Anyways. Sorry.
Thank you so much, Doug. No, that's really nice to hear that we're not just flailing around in the dark.
Right. No.
Super. Okay, Allison has been patiently waiting with her hand up.
No, just super quickly. I really appreciate what Alan says as someone who has a degree in art therapy and only did the exact minimum amount of sciences I needed to. Medical school was an interesting experience. I just want to really just speak. Thank you so much, Jean and Laura. That was an amazing talk. And I want to really say that anyone who wants to engage in the discussion, the family medicine MD stream had quite a few applicants. Like, it was really very popular. We've picked eight students, and anyone who wants to be involved in engaging with the discussion of how we evolve that, or who wants to be involved in taking a student on a longitudinal basis, starting from the beginning, please get in touch with either myself or Sylvie Casey, because I think how we evolve this, and we work very closely with Laura and Jean and Carol, but how we evolve this will also be important in how we evolve the undergrad curriculum.
Thank you, Allison. Yeah, it's fun times with that stream, right? You're you're really getting to be quite creative in terms of how you're going to approach it. So it's fabulous. Okay, well, lots of people have been leaving. I did put in the chat that if you had ideas that you wanted to share, please send them to me or to Jean in an email. I don't have Jean's email by heart, but I put mine in the chat. I really want to thank everyone for coming and for participating and for bringing your energy and enthusiasm to this really important issue. And I hope you all have a great day.
Yeah, thanks so much, Laura and Jean. We're going to have you back. This is an ongoing conversation. Okay.
Actually, speaking of which, a little promotion. Allison is leading something at the DFM retreat on this topic.
We are doing it together, Laura.
Oh, well, you're leading it though, but anyway, whatever.
Okay. Please complete your evaluations of the session. Much appreciated. See you all. Happy summer.
Thanks, guys. Bye.